This lecture is going to be on osmolarity and osmolality. Osmolarity and osmolality are similar terms in that they both refer to the concentration of particles in a solution. However, osmolarity expresses the concentration of those particles in a set volume, whereas osmolality is a measure of those particles in a set mass. Osmolarity is a calculated value using sodium, potassium, glucose, and BUN, and osmolality is a measured value using an osmometer. All of the osmoles in blood are not included in the equation for osmolarity. Therefore, the calculated osmolarity is only an estimate of the actual concentration of particles in blood. However, osmolarity is helpful in that it is typically an estimate for intracellular osmolality and therefore can be helpful in identifying cellular dehydration. Osmolality is most helpful in identifying unmeasured osmoles. An ineffective osmole is a particle that freely passes through a semipermeable membrane. So, the concentration of ineffective osmoles rapidly equilibrates between the extracellular fluid and the intracellular fluid. And water is not retained within a compartment. Cell membranes are impermeable to sodium and glucose. Therefore, sodium and glucose are effective osmoles. This means that they can retain water within a compartment and can contribute to the osmotic pressure of a system. A colloid is an effective osmole with a very large molecular weight. And an excellent example of this is albumin. The osmotic pressure applied to a system due to a colloid is called the oncotic pressure. So why do we care about osmolarity and osmolality? Well, there are three instances in which osmolarity and osmolality are particularly helpful. And they are identifying marked hyperosmolar states, determining expected physiologic responses, and also identifying unmeasured osmotically active particles. Marked hyperosmolarity occurs when the osmolarity exceeds 350 milliosmoles per liter. This can occur with severe dehydration, salt toxicity, or hyperglycemic hyperosmolar syndrome. In all of these instances, there is severe cellular dehydration. The organ that is most appreciably affected by this dehydration is the brain. So, oftentimes these patients will present in a stupor or with neurologic signs. Rehydrating animals with marked hyperosmolarity must be done cautiously, and that's because rapid administration of IV fluids can cause rapid cellular rehydration and therefore edema. With rapid rehydration, cerebral edema can actually worsen the patient's neurologic signs. Hyperosmolality causes release of ADH from the pituitary, which acts on the kidney to resorb water from the ultrafiltrate and therefore concentrate the urine. So, an appropriate response to hyperosmolality is concentrated urine. If this isn't present, then the reason for the abnormal response must be identified. Diabetes insipidus, or DI, is when the pituitary fails to produce ADH or the kidneys fail to respond to ADH. If the dysfunction is in the pituitary, then the disease is called central diabetes insipidus. If the disorder is due to a failure to respond to ADH, then the disorder is called nephrogenic diabetes insipidus. Causes for nephrogenic diabetes insipidus include hypercalcemia, hypokalemia, E. coli endotoxemia, as well as Cushing's disease or hyperadrenocorticism, and hyperthyroidism. Diabetes insipidus typically doesn't cause hyperosmolarity if the animal has free access to water, but if there is limited access to water, then hyperosmolarity can develop. The osmo gap is the difference between the measured osmolality and the calculated osmolarity. The osmo gap is increased when there are greater concentrations of unmeasured osmoles in blood. These unmeasured osmoles are either toxicants or intravenously administered substances. The osmo gap is most frequently used to diagnose ethylene glycol toxicosis. Since you've already learned about ethylene glycol causing acute renal failure, this slide summarizes the laboratory changes that you see within 3 hours of antifreeze ingestion before the animal has acute renal failure. Antifreeze contains a rust inhibitor and ethylene glycol. The rust inhibitor contains phosphorus, which can cause a mild hyperphosphatemia. Ethylene glycol is an osmotically active particle, and when it is in plasma, it increases the plasma osmolality and stimulates ADH release. ADH then stimulates the thirst response, and the animal becomes polydipsic. Ethylene glycol molecules draw water into the tissues from the tissues into the vascular space, and this results in mild reductions in the PCV and the protein concentrations. Ethylene glycol is excreted in the urine, where it also acts as an osmotically active particle, and it acts to retain water in the ultrafiltrate. So this is one of the causes of osmotic diuresis. This osmotic diuresis ends up decreasing the urine-specific gravity. The release of ADH due to hyperosmolality should stimulate water resorption, but the ADH cannot override the effects of the osmotic diuresis. Overt signs of ethylene glycol toxicosis do not become apparent until greater than 6 hours after ingestion of ethylene glycol. So after 6 hours, you would expect to see signs of acute renal failure, a titrational metabolic acidosis, as well as calcium oxalate monohydrate crystals. So hopefully, by noticing these changes early, you can start treatment early and not diagnose the animal after it's become too late.